Here comes Dr. Ina. I'm going to add her. I'm so excited for this conversation. Here she comes. Dr. Ina is a board certified. Hi, Ina. How are you?
Well, thanks. How are you?
I'm well. Thanks so much for
Good.
joining us. I know
Sure.
everyone's
Thanks
really excited to hear from you.
Yeah, thanks for having me.
Yeah, so I was just introducing you as a board certified ear, nose, and throat
Mhm.
doctor with a subspecialty in laryngeal
Laryngology.
Laryngology. I always
Mhm.
think it's the G, but laryngology. We're so lucky to have you. You've been published in over 30 peer-reviewed studies with your background at Northwestern and Harvard. And thank you so much for taking the time to talk with us about LPR.
Sure, happy to. It's a topic that I love and love to educate on. So thanks for this platform.
Yeah. Before we start,
Mhm.
is there anything that else you'd like the listeners to know about your background, who you are, what you do?
I do share this on social media all the time, but I think I got a passion for LPR because I suffer from it as well. And
Mhm.
so I think it turned into kind of initially being very curious, trying to look for answers, trying to educate myself first. And then that now that's turned into educating my patients, my followers, as well as advocating for them. So I think that's why I'm so probably passionate about this topic, is because of that personal relationship to it.
Yeah, thank you for sharing. I can definitely relate to that as well. And what really drew me to your content is the way that you speak about LPR and its different facets, the different types of LPR. And maybe we can just start with an overview on like what LPR is.
Sure. So, LPR stands for laryngopharyngeal reflux, and essentially it is a host of symptoms involving kind of what we call the upper airway, right? So, kind of the back of the nose, the throat, the respiratory system. And it's a host of symptoms that we believe are caused by reflux, so reflux affecting the throat. Our American Academy of Otolaryngology here in the US, which is basically our premier professional society for kind of all ENTs, defines LPR actually as both the direct, so direct tissue damage, and indirect effects of this reflux on the throat. And I think that's kind of where a lot of the subtypes and kind of the nuances come in terms of managing LPR, because it's how reflux can affect your throat, even if reflux isn't touching your throat.
Right. And I think that's a really important thing to note. And people sometimes feel like I don't have acid reflux because I don't have heartburn. Is
Right.
that something that you hear pretty
Yeah.
frequently?
So we hear that a lot, and it's actually not uncommon. The reason for that, a lot of times people will call LPR kind of the silent reflux, is because you may not feel the actual, what we traditionally known as reflux symptoms occurring, such as that heartburn, indigestion, regurgitation. But the effects of the movement are still happening, and those are the symptoms you do feel, like the chronic cough, the postnasal drip, the globus or lump in the throat sensation, pitch breaks, voice changes, all of that.
Got it. And why are those happening in the body? Why do we have the throat symptoms even when, there isn't a sense of heartburn or a sense of awareness of the reflux?
Well, it's thanks to what's known as your vagus nerve. So it's the big major kind of sensory nerve in the body, and the vagus nerve gives branches in not only kind of the esophagus and the GI system, but it gives it in the throat as well. And so we think a lot of the non-direct kind of effects are basically nerve-mediated symptoms. So essentially, the way to explain this to patients is your body has mechanisms in the throat to feel what's happening in your esophagus. So we have studies, a lot of them from kind of overseas in Japan and stuff, where they would place catheters in the esophagus and dilate the bottom of the esophagus. And guess where patients feel the discomfort?
In the throat.
Right in the throat. So patients will immediately grab their throat as, oh my God, there's pressure. But it's really the balloon is being dilated distally. We also have studies similarly with acid. So they will place catheters and drop a little bit of acid distally, meaning lower down in the esophagus. And where do patients feel the pain? In the throat. So
Mhm.
there's a lot of connection between kind of the airway or the throat and what's happening lower down in your GI system.
Okay. So is it sometimes also the irritation from acidic reflux that irritates the throat passages? There's
Yeah.
more so the vagus nerve or both?
Can be both. So there is, again, with the definition, we talk about both direct and indirect. So direct basically means the tissue is directly being irritated or damaged by that refluxate. So in some patients, the reflux actually comes all the way up into the airway, okay, and all the way up into the throat. And then that causes a lot of discomfort and burning and inflammation, and that needs to be treated as well.
Okay. And maybe we can talk about the difference between non-acid and acid reflux. That was fascinating to me when I first heard you speak about that. So maybe you can
Yeah.
share a little bit more on that.
So I think this is again where kind of the nuance of LPR comes from. I mean, when the term and the definition was first brought about, a lot of emphasis was placed on acid, right? Most of us in our mind, I always think to that, what was that 1960s match game where someone would hold up a word and then you had to hold up another word. And so if someone says reflux, almost everybody, if I ever say that to patients, they'll say, oh, acid reflux, right?
Mm,
So acid was very much intertwined with the idea of reflux, probably because most of the symptoms involve some sort of burning sensation. So what's important to understand, the reflux by definition is just movement. So it just means kind of what's in the stomach is moving upwards. Now, there's a certain amount of that that's actually physiological, we don't worry about it. Doesn't cause symptoms. So it's not that we're trying to get rid of what your body naturally does, but when there's excess movement or that movement is heavily acidic or a lot of volume associated with it or comes high up, then it starts to cause symptoms. So when we think of what could possibly reflux or move up, we often think of acid because acid is our stomach to digest it. But it's not our only digestive enzyme, right? So the body digests food also using something known as pepsin, and pepsin is a non-acidic digestive enzyme. And what we know is that they kind of work in combination to help with that. So if they work together in the stomach, they can also come up together, including things like bile salts, when patients have reflux. So you can't just reflux acid. You often bring that pepsin up with it. And pepsin is essentially the marker. So when you see studies on pepsin, what they're really trying to show is that reflux does happen up to the throat. We have studies where we've seen pepsin in things like ear fluid drainage from babies, from the back of the nose, from chronic sinusitis. Pepsin should not be there unless it came from reflux. And so that's kind of the leaps that are kind of taken with some of this research is pepsin is a marker for that kind of non-acid reflux and causing
mhm.
damage. We also know with studies that pepsin is sneaky. Pepsin is the little ninja of reflux. Okay, so what happens is when pepsin can come up, it is most active in an acidic environment. So if your meal was heavily acidic or you have something acid after that episode happens, pepsin will get activated. Pepsin is very damaging to tissue. And again, this is all evidence based, where basic science research is being done to show that pepsin can damage cells. Pepsin is also sneaky because it can hide in these cells. Okay, so when the pH goes up and things are more basic, pepsin kind of becomes somewhat inactivated, but it can be reactivated when it's exposed to acid again. And so this is the very complex part of for some patients LPR where they are doing the diet changes but symptoms kind of come back or they're harder to manage because it might be more non-acid reflux or a pepsin problem than acid.
And what are some ways that you manage the pepsin related issues in the
Sure.
throat?
So currently we don't, excuse me, currently we don't have a direct kind of anti-pepsin product that is available in the market, but I do tell patients there is hope because there is a product that is coming, but it is just not quite here yet. So generally the ways that pepsin reflux is managed is the way that we manage all types of reflux, right? So my practice is very much aimed at addressing reflux as a mechanical process as opposed to kind of directly addressing pepsin, which because I don't have that option right now, or even directly addressing acid. So ways that we treat patients, and this is depending on whatever type of LPR you have, I always give my patients options. So the type of patient you are yourself. So some patients really just want something to try and take. They just want to feel better now. Sure, the education and the theories and everything are great, but can you just give me something? Okay, so we have that camp of patients. And then we have the camp of patients that need to know why. Why is this happening to me? Why am I having reflux? Let's get to the source of it. So that's my second camp. Most people, somewhere in between. Okay, so the
Mhm.
ways that we can treat this, definitely for most reflux, I talk to patients about primarily diet and behavior. Okay, so for most of us, reflux is very much diet triggered, or how we eat, when we eat, and drink can cause that. Secondarily, I talk to patients when we're doing a workup to find out kind of the root cause, right? For some patients, it may be an H. pylori infection that can be treated. It may be something structural, such as a hiatal hernia, okay? Esophageal dysmotility. It might be the effect of some medications you're taking, okay? So medications can also trigger reflux. If we think it's primarily an acid problem where patients are kind of overproducing acid or just eating a lot of acid, and we've recommended diet changes, but they continue because the reality is it's very difficult to give up everything that you enjoy eating and drinking. That's where the role of kind of acid suppression comes in, and why you will see that a lot of times is the primary way it's treated. I don't agree with that, but that's what patients will find out in the world, is that acid suppression is
Mhm.
usually the first line. I think the reason for that is these acid suppression medications work really well for acid suppression. So they really turn that acid off. Patients feel a lot of times relief soon or quickly. And so it validates that, oh, this is really working. The problem is we know that acid suppression, especially in the form of proton pump inhibitors, unfortunately, does have potential side effects that really need to be discussed with patients before they start taking them chronically.
Mhm. What are your thoughts on the long-term use of famotidine versus a PPI?
Yeah, so those are two different types of acid suppressors. So famotidine, also branded name Pepcid, works on H2 blocker, or is an H2 blocker. And then we have our proton pump inhibitors that work on the proton pump. So the PPIs, which are your Zols, your omeprazole, your pantoprazole, those are very strong acid suppressors. And the truth is, they really work, right? They really turn off those pumps. And so for patients, and there are some patients that are indicated to have acid suppression, they're great drugs. The problem is that a lot of these, a lot of them are over the counter. So patients can just get access to them without really the discussion of like, how long should I take this? Should I continue to take this? When can I stop? Acid is important. It's there for a reason in your stomach. So acid isn't necessarily the enemy. Acid is important for digestion to help you absorb things like calcium, magnesium, and B12. And so you can imagine chronically, if you are suppressing your acid, there are going to be issues with those absorptions, right? So calcium, magnesium, and B12, especially for my female patients, we're usually kind of low in calcium as it is, especially if you're lighter weight, if you're Caucasian, more risk of things like osteoporosis. So we just really need to be mindful. I will be upfront and say, this is how I counsel my patients when I'm talking to them about PPIs. But if we actually look at the literature, unfortunately, the literature is not the best type of studies out there. Okay, so most of these studies are retrospective, meaning looking at data sets from the past and looking for correlations. So correlation is very different than causation. So if you talk to some of the primary investigators of these studies, they will say, we didn't say proton pump inhibitors caused this. We just said there was a correlation. So
Mm.
take what you will with that. I think it's enough for me to recommend, if you really don't need to be on this long term, let's try to get you off. Most of the studies showing those kind of long term risks are with proton pump inhibitors and not H2 blockers. With H2 blockers, the big thing I usually bring up with patients is if they have any sort of kidney history. That's really where we see it. They are considered, generally safer than the proton pump inhibitors.
Mhm. What are your biggest tips for your patients struggling with LPR? If you're gonna, I don't know if you give a lot of, you don't have a lot of time in
Mhm.
session to give nutrition advice. I'm sure you refer out to dietitians for this as well. But if you have time in a session, are there some tips and takeaways that you give patients in terms of lifestyle, nutrition?
So I really rely on colleagues such as you, Molly, to really
Yeah.
kind of hone in on those. That's where your expertise is, and I value that. And I think collaboration is the key. I think when I'm with the patient, I mean, my first role is to try to get them an accurate as diagnosis as I can, and so that really
Mhm.
involves kind of my physical exam and doing a good exam of the throat and the larynx. I focus a lot on education in terms of the process. So I think there's a lot of relearning that I have to do with patients because, again, they're coming in with an idea of what acid reflux is, and I
Mhm.
have to break it down into mechanical reflux and the digestive process. So we spend a lot of time. I think it helps with a little bit of patient buy-in to really spend the time to educate. And then we transition into kind of the idea of diet. Now, the thing with diet is generally when we give guidelines, they're kind of blanket statements, right? So we say things like, avoid things like coffee, caffeine, eating late at night, really heavy meals that can distend the stomach. Alcohol is a big trigger. Smoking is a big trigger for lowering that lower esophageal sphincter. So I have a handout that I give my patients that have kind of these blanket statements. And I'm very upfront saying, listen, not all of these might be triggers for you. Okay, they might not be, but there's no way on my exam I can tell you what your trigger will be. And this is where some of the ownership comes in. I've done my good exam, I've done your workup, I've made sure you're safe, but let's get you feeling better. And that's going to take a lot of buy in from the patient, right? So, different types of eliminating certain things for certain people. I give anecdotal stories. I've had patients just give up carbonated water, like literally that
Yeah.
was it. And their throat symptoms got better. So,
Yeah.
if you're in that camp, that's fantastic that you were able to identify a trigger. Sometimes, unfortunately, for patients, it feels like almost everything triggers. Even I've had patients say even water, and yes, even water can reflux. But those are the patients I think we need to take a little bit more care with, probably see a little bit more often, and really work through the diagnostic options to get to the root cause.
Absolutely, absolutely. In terms of diagnostic options, I heard you mention like esophageal motility.
Hmm.
What or is an endoscopy and a motility test some of your go-to tests, or are there other
Yeah.
tests that you typically perform?
Yeah, so I'll kind of tell you kind of everything that's sort of available, right? And so, first, whenever anybody has a throat symptom, we have to look at your throat, okay? Because we're talking a lot about LPR. LPR truly is very common. But we find bad things too sometimes, okay? Not to scare anybody, but if you have chronic throat symptoms, please come in. Please let an ENT or laryngologist, such as myself, look at your throat and truly say, yes, we think this is related to reflux and not something else like an infection or, a fungal infection or even, unfortunately, tumors and things like that we can find with some of these symptoms. So, first, get checked out. Now, it's important to understand that that scope exam is not really considered diagnostic for LPR. And again, being very upfront with patients. I do this because I need to make sure it's not anything else because we're talking about part of your body that I can actually see. And then from there, what we do is we talk to patients about the suspicion that LPR reflux could be playing a role. Okay, so it's very important to understand that it's not truly diagnostic. There are findings that make us more suspicious along with your history. That might be enough for some patients to say, well, let me try the diet first. Let me try some acid suppression if they're in that camp. Let me try some things such as alginates to see if my symptoms get better. For truly diagnostic purposes, though, I tell patients there's a couple of different options. The gold standard is called the dual 24-hour pH impedance test. Now, this test isn't the most comfortable or readily available, so oftentimes it's not offered kind of at the first visit. But essentially, what it is a small catheter goes through the nose into the esophagus, and for 24 hours while you're at home, eating, drinking, sleeping, it is recording reflux. Okay, and it's looking for that acid and that non acid reflux. Um, Again, it's not the easiest type of test to have access to or maybe even tolerate for some patients. So, another test that I offer patients a lot is something known as a barium esophagram. Basically, a barium esophagram is where you drink barium. Barium kind of shows up on a moving x ray, and the radiologist can see, is there dysmotility, meaning the esophagus doesn't bring things down nicely? Is there a hiatal hernia? Is there volume reflux? It is not uncommon for me to find volume reflux in patients who do not feel volume reflux. So those are probably the two easiest. Now, upper endoscopy is very important as well for any sort of GI gastric symptoms. And so I always make sure my patients have that at some point if they've been dealing with these issues, especially for a while. But that also is not diagnostic. So equivalent to my ENT scope, the GI scope, both have value, both are very important, but don't rely on a diagnosis simply on that scope. Okay, you can have a normal ENT scope, you can have a normal GI scope, and you can still have reflux. Okay, so very important that those have their purposes, but they are not diagnostic.
Got it. Yeah, super helpful. I heard you mention alginates, and those are something that I use really frequently in my practice too, and I'd love to hear your thoughts on them and how you use them, and if there's
Mhm.
certain cases where you do or don't.
So I'm a huge fan of alginates. It was something I wasn't really taught or trained when I was in training. It was more something that came about with kind of, again, that self kind of education and investigation. So alginates have been used across the pond in our colleagues in Europe forever. So it's nothing new to kind of the treatment of reflux. It just wasn't part of essentially US culture or how we treat reflux here, unfortunately. So alginates are basically kind of derived from the word algae, and that's what I like patients to think about. Think of algae floating on the surface of your stomach. That's what alginates do. In that way, they really address mechanical reflux because they're weighing down those stomach contents so they're less likely to be able to come up. Alginates are great because most of them are kind of considered all natural. I will be upfront that I started using an alginate known as Reflux Raft, and I loved it because of the response I was getting from patients and myself and my staff members. Actually, we had a little bit of a reflux party there one day, and so I do educate for them now, and so that's one of the ones I'm mostly supporting because of that personal experience and that experience with patients. It's called basically an enhanced alginate. So the idea is that you have the kind of the algae properties, but certain nutritional aids are added to help with other components of digestion, like ginger and licorice and that sort of thing. So definitely, alginates are, I think, starting to get better known. They're starting to get more available, and I think it's a great option for patients looking for kind of natural ways to supplement their diet and behavioral changes because sometimes patients just need a little bit more support than maybe just diet and behaviors can offer. It's great for people like pregnant women, right? So pregnancy is really difficult for reflux and not a lot of super great options that most people feel comfortable with, right? So
Yeah.
when you're pregnant, you're going to be overly cautious because of the developing baby, and so alginates like Reflux Raft are great for that. They can be used during pregnancy. So I think it's just great to have options for patients.
Great. Yeah, absolutely. That's been so huge for my patients as well. Do you use, is there anyone that you wouldn't use alginates with, like children or teenagers?
No, I mean, it's indicated for adults. I have had some children use it, try it, and feedback has been good. Again, it's all natural. So if you're going to give, for example, kids can take things like Pepsid, pregnant women can take things like Pepsid. So if you can give things like Pepsid, you can give things like alginates,
Mhm.
right? So
Yeah.
that's the thing. It's like Pepsid isn't natural. It's a drug that works on, your acid pumps, but alginates are kind of all natural. Now, again, being upfront, alginates are not going to cure reflux from happening, right? So alginates work on the stomach contents, but because they're natural, they're not really changing your physiology at all. So again, being very upfront about how alginates play a role. But remember, proton pump inhibitors don't cure anything either, right?
Mm,
They only
mhm.
turn off the pumps while you're taking them. So for the certain indications where I'm supportive of proton pump inhibitors would be really like Bruce Springsteen recently just came out and said he has a peptic ulcer, right? Peptic ulcer disease. So it's
Yeah.
important for that type of healing. And
Mhm.
patients with Barrett's esophagus, proton pump inhibitors, I support the use for that. You really need that to heal. But if we are talking about LPR or reflux episodes, that is not my go to at all. So,
Got it. Got it. Can we circle back to the vagus nerve and the role that
yeah.
that plays in reflux, and what can we do to support, the health of our vagus nerve?
Yeah. So, really difficult question with really difficult, primarily unknown answers for this. And that's again being very open and upfront. I was in Turkey for a conference in April where I spoke about basically my slides were called Neurogenic LPR. It's very similar to what the gastro doctors will call kind of a hypersensitive esophagus. Right. So it's basically the idea that we don't think there's like high volume reflux coming to your throat. There's nothing being damaged. You haven't responded to kind of acid suppression. And so basically, this is nerve mediated. What triggers this hypersensitivity? Well, a lot of times it is viral infections. So, viral infections can increase sensitivity of nerves, both GI and in the throat. We do think chronic inflammation seems to trigger a protective response that even once the inflammation is gone, the tissue or the nerves are still heightened. Okay. And so neurogenic or vagal nerve issues with sensitivity are basically diagnoses of exclusion, right? We don't have a test where I can give you and say, oh, yep, your vagus nerve, it's hyperactive. It's more
Mhm.
based on symptoms and then excluding the things we do have testing for. So primarily when we don't think it's an acid problem, we don't think it's a heavily mechanical problem, you've tried the alginates, you've tried the acid suppression, we've worked you up for hiatal hernia and stuff, then we basically come to this category of neurogenic or hypersensitive, depending on who you see, what term they use. And then we'll use medications that basically work on nerve endings. Okay, so we're very much away from natural treatments at that point if we're using those type of drugs. And again, for the right candidate, I do recommend it just to give them some relief or offer some options. I think I also depend a lot, Molly, on specialists such as yourselves to see if we can figure out more kind of natural gut health. We know
Mhm.
gut health is an emerging topic in a lot of subspecialties. We know that it definitely affects the brain, right, and how we
Mhm.
respond to things. And so when my kind of medical pathway is not getting answers for patients, we try to kind of loop in and say, can we really hone in on what your diet consists of? Can we reset that gut balance to help with some of these symptoms?
Absolutely. I think both sides of the puzzle are so needed. I definitely
So
had
needed.
a lot of patients that had success with diet modification, meal timing,
Mhm.
stress management, identifying triggers, but also I had a lot of patients that had a lot of success with those nerve targeting medications. I think you're speaking about like nortriptyline, amitriptyline. Is that sort of the medication
Correct.
being
Yep.
used?
Correct. So, yeah.
Yeah, so absolutely. Thank you so much for
Of
sharing that. And I
course.
think
Yeah.
so I see really frequently in my practice
Mhm.
stress. My LPR clients really speaking about stress as a huge trigger. And when they go
Yeah.
away on vacation, maybe they notice their symptoms get better, or when they're not thinking about their symptoms, they get better. Can you maybe speak on the relationship between anxiety and LPR?
Sure. Yep. So we know stress triggers mechanical reflux. We know that happens. It also increases kind of acid production. Um, Everybody is stressed. Okay. Stress is just so common, and that we don't, I think, address it enough for patients. So, uh, stress can be a primary cause for reflux, but it also exacerbates if you have another reason for reflux. So, I always tell patients because they'll come in and say, my doctor says these symptoms are just anxiety. And I look at them and I say, listen, anxiety, it's pretty common. We all have it at times, but let's just not put all our eggs in that basket right now. Okay. Because what we're going to do is we're going to try to figure out if there's something else that I can help you with. And guess
Mm-hmm.
what? Some of that anxiety might get better because feeling like you can't swallow, feeling a lump that doesn't go away. I mean, I'm just thinking about it and I'm getting anxious, right? So,
Yeah.
how do you know if it's the anxiety first? Like, which one came first? So, let's not put all of our eggs in that basket. Let's think maybe there is something medical we can address, something physiological we can address, and then we'll combat the anxiety as well. So it's not
Hmm.
uncommon in my practice for me to kind of have this type of discussion with patients and just be very like, listen, I'm not putting any sort of blame game on anxiety. Who does not have anxiety? And those feelings can trigger it. But let's also work hand in hand with kind of the diet and the alginates and the diagnostic workup, and then perhaps let's also address some of this anxiety with cognitive behavioral therapy, acupuncture. If you like yoga and you can do it, have at it. That's awesome. Go spend time with family and friends. Go on that
Hmm.
vacation. Let's try to kind of holistically treat these symptoms.
Yeah, absolutely. That's really aligned with how I talk about LPR and stress management for gut health as well. We had a couple questions submitted.
Oh,
If we have time,
yeah.
one of them is about alkaline water. What are your thoughts on the use of alkaline water for LPR?
Yeah, so I was kind of, a little bit mixed all over the place. I did recently come across a study that showed that it does help. So remember we talked about pepsin being primarily active in an acidic environment, and then it can kind of hang out. So the idea behind alkaline water is actually benefits perhaps in the throat as well on the way down. So when you drink that alkaline water, you potentially could be kind of soothing some of that pepsin mediated drama or trauma.
Mm-hmm.
And so, I don't see any downside to it from a medical standpoint. Now, alkaline water, you probably are paying more for it, right? If you're getting it bottled and things like that. So there is a certain cost, but the reality is a lot of these diet changes are associated with cost too, right?
Mhm,
So there is a certain privilege to be able to change your diet and make
mhm,
choices about your diet that we have to be realistic about, that that is not cheap. And so same with alkaline water. I don't see any medical downside to it. I think adding it to your regimen is great. We encourage drinking water. From an LPR diet standpoint, there's not a lot of other drinks we can recommend. And so we see this often that it's really just water. So if you're going to choose the water, choose more of an alkaline one for that
mhm,
benefit.
mhm. Another question that came up frequently was, is LPR damaging the tissues of my throat? And you sort of already spoke about
Yeah.
that with pepsin, but how do you answer that question when it comes up with your patient?
It's difficult because we know acid reflux with primarily GERD can damage the esophagus, and that's what's known as kind of the first step is Barrett's esophagus, and that can unfortunately turn into things like esophageal cancer. A lot of our older literature would just kind of supported reflux contributing to things like throat cancer. It's very complex though, because what we're talking about, I mean, those studies are talking about acid reflux hitting your throat, which makes sense if you're pouring acid on tissue and it's uncontrolled. Of course, it can trigger for that. There is a study looking at pepsin in vitro. So, again, not in the body, but in vitro, like in cells. And it showed that continued exposure to pepsin did start to cause those cells to change in ways. Cells changing can always be concerning for precancerous change. Okay. Um, I also don't want my patients to be overly worried, right, either. So it's not that I'm trying to say, oh, you got to treat this because I don't want you to get throat cancer. That's not at all. But what it really is a thing of monitoring, right? When we do our
Mhm,
initial scope, just like GI does their scope, that provides reassurance that things look good. And from here, moving forward, we're going to get a better handle on symptoms. So if there's nothing now, we don't anticipate it later. Now, anything changes with the throat, I usually have my patients come back in if they feel anything different, but also kind of as a routine kind of follow up to monitor as well. So it's very different than GERD in terms of that risk.
mhm, yeah. And our other question was, if someone is having, continued acid reflux,
Mhm.
do you often see LPR in the later phases of reflux, like continued reflux, or are they kind of two separate conditions? Like, does
Yeah.
continued reflux cause LPR?
It's a great question. We see both categories. So if you have true GERD, you're at a higher risk than the general population of developing LPR, which just makes sense, right? Like because you already have reflux, why wouldn't your upper airway at some point get affected, right? LPR is tricky because we don't see the reverse. So a lot of times what we see with that is primarily LPR symptoms, and we don't see the GERD symptoms. And so I think for most of us, we're starting to really think of them as two different pathways. Initially, I think when the term came out and how it was used in kind of medical practices was really that it was one umbrella term. And I think I use that often. I used to use that too, saying, oh, everybody knows GERD. And one of the offshoots of GERD is LPR with the extra esophageal symptoms. But as I'm growing and I'm getting more kind of learning more, seeing the research that comes out, I'm really starting to really transition that as opposed to being two separate kind of processes, as opposed to LPR being under GERD.
Mhm,
Perhaps we could put the acidic LPR under GERD, but
mhm,
really this nuances of the neurogenic and the pepsin mediated, I think we really should think of it as its own disease now.
mhm. This was so comprehensive and informative. I can't thank you enough. I
Yeah,
know I'm
thank
gonna
you.
get so many messages, and I'm sure you are as well, just about how informative this was. And
Yeah,
thank you so much for, just explaining all this so clearly. It's such a confusing space to be in, and this
definitely.
I hope, to our listeners that this really helped really explain, some of the different types of reflux causes, different testing and treatment options. And I know we didn't speak a lot about the nutritional side,
Mhm.
but if you're listening and you're interested in the nutritional side, you can always check out my YouTube channel, my Instagram, my TikTok, my reflux relief one-on-one program. More information there on the nutritional, lifestyle, stress management side of things. But Where can people find more of your work? And if they want to learn more about you or your practice, how can they
Sure.
get in touch?
So clinically, I do see patients. I'm a full-time laryngologist. I'm actually located in Munster, Indiana, which is about 30 minutes from Chicago. I live in Chicago and commute there. And then also on socials, so Instagram, Ina Husain MD, and then on TikTok as Throat Doc. Always looking to connect. Always trying to help guide people. Um, I just one little shout out want to say I know sometimes it can feel so overwhelming because you're getting kind of mixed information. Maybe your providers don't actually really understand what LPR is, and it can feel kind of hopeless, to be honest. But reach out. Let's get you connected to a team that can kind of help you. I mean, there is hope. There is a lot of research being done. There are new products coming out. There's natural options. And so just don't give up. Don't give up. Let us try to help guide you.
Yeah, absolutely. Such an important message. And I will link your information down below for our listeners. I'll also link Reflux Raft. And oh, I wanted to add another question that,
Yeah.
our listeners may be thinking of now is what would be the best way to find an ENT in their area if they're not close to you?
Yeah, so I generally, I generally, because I'm a laryngologist, I usually tell patients laryngologists might be your best bet to help coordinate some of this. Now, being again very upfront, remember practice patterns are very different across the country. Medical education is very varied, personal interests are very varied. So, the reason I say laryngologists is they're going to be the most probably in tune to this,
Okay.
but it might not be your last stop. Okay,
Yeah.
so I would say ways to find laryngologists. Generally, most of us are under some sort of voice center or voice program because that's a big part of laryngology. Speech language pathologists, if you work with one, know of some, they usually know where the laryngologists are. And unfortunately, some areas may just not have laryngologists. So, ear, nose, and throat doctors are very able to take a look at your throat and help guide, but just advocate for yourself, right? So,
Yeah.
if you're not finding that, say, hey, do you know a laryngologist? Do you know someone who specializes in LPR? Is there a GI you work with who treats this? Just ask those questions of your
Mhm.
provider to help find someone near you.
Absolutely. Thank you. Yes, and Dr. Ina and I both share a lot of free information on our pages, so definitely take advantage of that. But thank you again so much.
Yeah,
It
it's
was so
great. Yeah.
valuable.
So thanks so much, Molly. I had a great time.
Yeah, thank you.
Okay.
And I'll be in touch. Thanks so much.
Bye.
All right, bye.